Why we need to discuss this topic? Low flow anesthesia. Why? Most of the PGs are knowing that thing. Less wastage. We know. Less expensive. That also we know. Safe. Provide warm patient. Planet friendly. Steady state of anesthesia. Everything is written in the book. And most of us are knowing. So we are not going to talk on this. We are going to talk rest of the thing related to low flow anesthesia. So are you aware of these facts? Altered patient physiology and damage to the respiratory tract with the dry and cold gases? Yes. Wastage of how much wastage of money we are doing? We'll calculate. Environmental hazards, we know. Important and ill effect of gases, anesthetic agent to us. How many of us are knowing? What happens when we inhale the anesthetic agents or nitrous? So usually, when we inhale gases, when we are awake, when we inhale gases, the gases reach the 36-degree temperature and 100% humidity at third generation of bronchi. But when patient get intubated, this isothermic point shifted down 10 centimeter in the bronchi, which are not capable of handling dry and cold gases. And this can lead to hypothermia and epithelial ulceration. And if you look at a long-term way, it is to post-op pulmonary complication. So if you consider, this is through a simulation, 2 hour cost of CO fluid anesthesia with the 4.5 liter is 2320. And 4 hour is 4000. If you reduce the flow to 0.6, is 590 for 2 hours and 900 for 4 hours. So if you are running a OT 4 hours a daily, the cost saving will be 3100. For a month, 4 hours a day for a month, 93,000. An year, I think you can get that machine free in a year. What do you know by global warming? सुनते रहते हैं. See, there are 3 layers of Earth. Stratosphere, ozone, and troposphere. So, ozone is a layer which prevents ultraviolet radiation over the Earth. And most of the halogenated hydrocarbons destruct that layer. And it allows ultraviolet radiation on the Earth. What is greenhouse effect? How many of you know greenhouse effect? Most of, specifically ISO, is greenhouse gas. What it does? It absorbs the energy emitted by the Earth and give it back to Earth. So that's the reason they causes the global warming. And there are certain potential, global warming potential, ozone depleting potential, and that potential are maximum with the nitrous. What's the half-life of nitrous? 110 years. So आपने अभी जो छोड़ा है ना, आपके बच्चों के बच्चे लेने वाले हैं. So this is most important of all the adverse effect of gas. And this book was published in 1999, almost 25 years back. And they have mentioned the adverse effect of the inhalation agent, anesthetic gases. Short-term exposure, most of you have felt it. Irritability, headache, many times drowsiness, lack of concentration, difficulty in judgment and coordination, nauseating. So these are still acceptable. चलो चलेगा, एक दिन हेडेक होगा, दूसरे दिन नहीं जाएंगे, कुछ करेंगे. But what about this? If you expose daily to these agents, miscarriage among the OR room workers, genetic damage, cancer among the operating room workers, over and above that, miscarriage in the spouses of exposed workers. and birth defect in their offspring. So it's not about environment, it's not about cost, it's about us. And that's the reason we have to have low flow anesthesia in OR. So this part we'll discuss during the discussion. So we are going to talk on the basics, physics and mechanics of low flow. So how many of you are aware of time constant theory? 12th की book में था. It's very simple physics. So this theory guides us how agent travel from one area to another area, from machine to patient. And we can predict the timing of traveling also by using this theory. Fine. So, none of you are aware of time constant or aware of? PGs? Fine. So, suppose this is a glass. It's a 100 ml of glass. 100 ml glass contains 100 ml of water. Fine. So, what is the volume of water in the glass? So, you can interrupt in between. So, it's a question answer session for 1.5 hours. Fine. So, I am not going to talk one way. So, effective volume in the glass is 100 ml. Fine. So, now you are pouring 100 ml of milk in the glass every minute. Suppose you are pouring 100 ml of milk in the glass. So, effective flow of the milk is again 100 ml. Fine. Are you going to get 100% of the milk in the glass immediately? Yes or no? So, when you are going to get?
After 100 minutes?
After 100 minutes? Never. Never. It keep diluting, you will never get 100% milk. You can reach near to the 100%. जो आप मशीन में से डाल रहे हो ना, तो पेशेंट में 100% जाता है. This is the answer. What you think, what I am delivering, that is going to the patient, is not. Okay? So, when you are going to get 100% of milk, that is not possible. You can't. But you can reach near 99.8%. Okay. So, time constant theory is a effective volume divided by effective flow. Volume divided by flow. So, for this simulation, effective volume is 100 ml. Effective flow was 100 ml. So, time constant is 1. So, at the end of one time constant, for this simulation is a 1 minute, you will be having a 63% of the milk in the glass, rest is water. At the 2 time constant, you will be having a 86.5% milk in the glass, rest is water. Getting the idea? Okay. At 3 time constant, you will be having 95% of the milk in the glass, rest is water. And at 6 time constant, you will be having 99.8% of the milk in the glass, rest is water. So आप जो डिलीवर करते हैं ना, अगर टाइम कांस्टेंट 1 है तो 6 मिनट के बाद अंदर होने वाला है. That you have to think. Fine. So this is interesting video. First minute, indigo dye and water, mixing the water in the indigo filled glass. Second time constant, getting diluted, 86.5. 3 time constant, 95. See, this theory is very important. That's the reason I am repeating again and again. 4 time constant, 5 time constant. 5 time constant. Getting clear, almost getting clear. And 6. Look, almost equal. Almost equal. Got the idea? Okay. So, when we are delivering anesthesia, we are having a machine, patient, and in between circle and circuit. So, there are 3 components. First, machine. Second, circuit. And third, patient. Fine. So, now, what you are delivering from the machine will take 1 time constant. 63% will be there in the circle after 1 time constant. At the 2 time constant, 86.5. 3 time constant, 95. And 6 time constant. So again, time constant is the effective volume divided by effective flow. So that's about the first compartment time constant. Means traveling time from machine to circuit. What is the second compartment time constant? When we don't have a directly from circle to the patient, or you are not attaching the, you are not using the closed, you are using open circuit. Then what is the glass of volume and what is the flow? Fine, we'll take it that later. One another example. Suppose now I am conducting a case with 0.5 liter of flow. Fine. So effective flow is 0.5. And when we are using the circuit, any machine, we need to ask the company about the volume of circuit. Because we need to know the volume. So usually it ranges from 4.5 liter to 8 liter. We have to ask the company what the circuit volume of this machine. But for a practical purpose, today we are going to focus on 6 liter. So suppose our circuit volume is 6 liter, that includes the circle, that includes the volume. 6 liter. Now, 6 liter volume and flow is 0.5, that we have said. So what's the time constant? Fine. That keep in mind. 12 is a time constant. So now, suppose I am conducting a case with 0.5 liter of flow. After 1 hour of surgery, there is sudden hypotension. What is the common reflex? Shut down the vaporizer. True? Karte hai. Now, what is the now? See, glitch is that what's the time constant here? 0.5 liter of flow? 12 minutes. So whatever the changes we are making on the dial, that is going to reflect in the machine when? 72 minutes. Then you are thinking that I am treating the hypotension. You are not. You are not treating the hypotension. We'll take another scenario. Sudden there is an increase in the BP. क्या करते हैं हम? That is going to reflect. If you keep the 1 liter of flow, so what will be the time constant for 1 liter of flow? 6 time constant. That is going to reflect in the circle. I am not talking about the patient. In the circle after 36 minutes. And we all are thinking that I am treating the blood pressure. So this concept needs to be changed. We'll discuss over a period of time how to make use of dial concentration and flow to control the hemodynamics during the low flow anesthesia. So now coming to the second compartment, from the circle to the patient. What is the volume, effective volume? ग्लास तो निकाल दिया, पी के छोड़ दिया. Nearby. So here, amount, what is the amount of air to be inhaled by us in a minute? I know, all of you know, but it's a twisted question. Amount of air to be inhaled by us in a minute. Minute ventilation. Fine? And amount of air which remains in the lung after normal expiration. That is FRC. So that is our volume. So FRC is effective volume for us when we are not using closed circuit. But when you are using closed circuit, from circle to patient, then FRC is our volume. Now we'll thinking of the open circuit. Now what is the flow? Effective flow. Volume to ho gaya. That is FRC is, what is the normal FRC? 50 ml per kg. For a 50 kg patient, we can keep it as a, for easy calculation, we'll keep a 2.5 liter. So 2.5 liter is the FRC. Now effective volume. Effective flow, sorry, volume is fixed. 6 liter, 7 liter, 5 liter, 4 liter. So what we keep on the machine, that is effective flow? No. So when whatever the flow we are keeping on the machine, whether it's a 5 liter, 10 liter, 15 liter, if it is possible to deliver 100 liter, if patient is going to inhale only minute ventilation from that flow, what we said. So effective flow is minute ventilation. That is around 90 to 100 ml per kg. That is come to 5 liters. Okay. So what will be the time constant for this stimulation? For open circuit. When we are not attaching the, using anesthesia with the open circuit. Most of us are pre-oxygenating with the open circuit. Many of us are. So effective flow is 5. Effective volume is 2.5. Time constant is 2.5 divided by 5. That is 0.5. So what we set on the machine, that will be delivered to the patient at 6 time constant. So 3 minutes. Clear? So that's the reason all the book mention 3 minutes of pre-oxygenation. Why 3 minutes? This is the answer. Okay. So actual agent traveling time is first compartment traveling time plus second compartment traveling time. So whatever you set on the machine will travel from circle to patient. So whenever during low flow, time constant is on higher side. So whatever the corresponding changes happening into the patient is also takes the longer time. So higher the time for change in the concentration in the circle. This part is clear? Everyone? Specifically PGs? Yes or no? Bolo yaar. So where we can apply this theory during the inhalation agent anesthesia? So those who are using closed circuit for a pre-oxygenation, pre-oxygenation should be done 6 time constant plus 3 time, 3 minutes. Because at the end of 6 time constant, you will be having 100% oxygen in the circle. Then continue for the 3 minutes. Okay, or else what you can do? Flush. Don't connect the circuit. Flush it for a minute. That will deliver almost 36 liter flow. So then what will be the time constant? 6 divided by 36, 1/6. So in a minute, circle will be having 100% oxygen. Clear? Then pre-oxygenation. So that is called priming of the circuit with the oxygen. Okay. You can judge the timing of corresponding changes which is going to happen in the lung or circle by using time constant. Even you can relatively predict the recovery also. बंद करते हैं तो कितनी टाइम में बाहर आएगा, you'll be able to judge with using this time constant. So during low flow, change in dial takes longer time to make the corresponding changes into the alveoli. So first message, there are total 6 messages. If you are keeping these 6 messages in your mind, you can easily conduct the low flow anesthesia. So delivered and inspired concentration are not same. Delivered concentration takes 6 time constant to reach the circle. What is this picture about? क्या है? Aged couple? How many of you are able to see the aged couple? All? And how many of you are able to see the young couple? Now you are able to see. So that is what anesthesia monitor is. वो दिखाता सब है, लेकिन हमको दिखता थोड़ा ही है. So if you are able to monitor, analyze the data on the monitor, you will be through with the low flow. So now we are starting the low flow. What are the concerns? How to achieve and maintain? When not to use? What are the requirements? Then what is gas volume deficiency? What are the other concerns? So what is low flow? So most of the data I have collected from these 4 publications and Dr. Ravi Shankar's lecture. What is low flow anesthesia? For practical purpose, we are considering 2 liter as a low flow anesthesia. So now, what is the amount of air to be inhaled by us in a minute? That is minute ventilation. So that is our requirement. That is our volume requirement. So if you have been supplied with lesser than that, that is low flow for us. Clear? So that's the reason Becker has given the definition in 1993. Any technique that utilizes the flow lesser than alveolar ventilation, means minute ventilation minus dead space ventilation, should be considered as low flow. So as per definition, if you are getting lesser than what our requirement is, that is low flow. Okay. So it's been divided into medium flow is 1 to 2 liter. If you are using 1 to 2 liters, we should call it as a medium flow. When we are using 500 to liter, that is actually minimal flow or low flow, and less than 500 is minimal flow. And metabolic flow means what is our requirement is. Only that much we are supplying. That is called metabolic flow. We'll discuss that part also. This is for PGs. What is the difference between open circuit and closed circuit? One is non-rebreathing circuit, that we call as a open circuit, and rebreathing circuit is a closed circuit. What is the difference between open and closed? So as name suggested, open circuit do not allow rebreathing to take place. It will not allow rebreathing. That is open circuit. So as open circuit do not allow rebreathing to take place, it's not possible for us to go down with the flow lesser than the minute ventilation. Simple. Now, closed circuit or semi-closed circuit allows rebreathing to take place, and that is the reason it enables us to deliver a flow lesser than the minute ventilation. Simple. Everything is in the circuit. Again, what is the amount of air to be inhaled by us in a minute? 30 times आने वाला ही है. Minute ventilation. So, what patient is going to inhale in low flow anesthesia is from the circle, not from the machine. So whatever the flow you are keeping on the machine, whether it's 5 liter, 10 liter, 20 liter, patient is going to inhale minute ventilation only from the circle. So circle concentration is more important than the dial concentration. Okay. So this is schematic representation of the circuit. This is inspire limb, expire limb, sample gas return line. So when you are keeping the fresh gas low, so this is the flow of gases, inspired, going to the patient, expired gases coming into the circle. If you are keeping the APL valve open, certain gas is going to be exhausted. Rest of the gases will go into the circle. And from the circle, whatever the oxygen concentration is there in the rebreathing gas, that is going to be rebreathed for the next breath. So whatever the oxygen is coming out, that is rebreathed in the next breath. Now, whatever the agent is coming out in a rebreathing gas, that is also going to be rebreathed in the next gas. So that is the reason we can save on the cost, because we are utilizing the concentration of oxygen and agent of expiring gas. Now, CO2 is get absorbed. So, in a circle, there are two components, two inlet. One, gas is coming from the expiratory limb, and gas is coming from the FGF inlet, fresh gas. So, circle contains the mixture of these two gas. That we should keep in mind. Now, when we are keeping the high flow, suppose we have set the patient minute ventilation 5 liter, and we are keeping the flow 6 liter. So rebreathing component will be automatically less. Clear? So what is the clinical importance? So when we are delivering the high flow, that high flow is directly going into through the circle, directly going into the patient. Whatever the dial we have set, patient is mostly going to get that. And that's the reason for first 10 to 15 minutes, we have to keep the high flow to achieve the proper concentration of anesthetic gas and oxygen into the alveoli. That is the reason initial 10 minutes of high flow is required, 15 minutes of high flow is required. Okay. Now, when you are using low flow, suppose we have set the minute ventilation 5 liter, and now we are keeping the FGF 0.5 liter. So, rebreathing component will be automatically higher. Fine. Now think that 5 liter, 0.5 liter FGF, that is 10% of the gas which patient is going to inspire. So whatever the changes you are make on the dial, that is going to impact only 10% of your anesthesia. Because 90% of the depth of anesthesia is depend on rebreathing gas. And that is the reason you can't change the depth of anesthesia speedily with the low flow anesthesia. And that is the reason you get the steady state of anesthesia. Clear to everyone? PGs? How many of you are PGs? Raise the hand. This part is clear? Okay. So, what is closed circuit and what is semi-closed circuit? Closed circuit, whatever the circuit you are using is semi-closed or closed? Is semi-closed. So, semi-closed circuit allows 150 to 200 ml of leak. Closed circuit, no leak. Very few anesthesia workstation is having 100% closed circuit. So in a semi-closed circuit, when fresh gas component is higher than the rebreathing gas, you can easily achieve the desirable concentration in the alveoli. because its fresh gas is higher. So that this should be used for achieving the depth of anesthesia within first 10 minutes. Then then start with the low flow. When you are using low flow, rebreathing component is on higher side. So the depth of anesthesia will depend on the low flow. Oxygenation will depend on the low flow. So with low flow you can easily maintain once you achieve. So and once you have achieved and you are continuing with the low flow, as discussed, it's very difficult to change the depth of anesthesia. It's very difficult to make huge change into the alveolar concentration. Confused or clear? Okay. So second message. There are two components of gases. What was the first one? हाँ तो याद करके ही छोड़ना है सबको. What was the first one? Huh? And that is second. First one. भूल गए. 10 minutes. Retention time is less. Inspired and delivered concentration are not same. It will take inspired delivered concentration takes 6 time constant to reach in the circle. And second is there are two components. ये अभी ध्यान रखना कि I am going to when we are going to third, fourth, fifth, sixth, I am going to ask all 1, 2, 3, 4, 5. So second message, circle is having two components of gases, rebreathing gas and fresh gas. During low flow, rebreathing component is on higher side, and so the depth of anesthesia and oxygenation is highly depend on the rebreathing gas. Clear? Okay. Now what are the concerns? Why we are worried about using the low flow? Most of us are, to start with, we are a little bit hesitant to start with the low flow. Why? What are the concerns? Different तरीके से सीखते हैं. So I am going to show you 3 videos. You have to identify the similarity and difference in 3 videos. Second, flowing little low. Third, flowing much deeper. Scuba, sea walk and swimming. What is the similarity and what is the difference? सरफेस पे तैर रहा है, थोड़ा नीचे और थोड़ा और नीचे. Yes, one thing. Pressure is a concern. Fine. So as you go down, you get the more pressure. So same thing happens with the low flow. As you go down, you need to require over pressure delivery. Now, second concern. As you are flowing on the surface, ऑक्सीजन की इतनी रिक्वायरमेंट नहीं रहती है. हाँ, बाहर आके ले लेते हो. As you flow down, bit down from the sea surface, you need to carry an oxygen hood. That during sea walk, fine. And if you remain under the water much deeper for a longer period of time, you have to carry a cylinder of oxygen. So same way in a low flow anesthesia, oxygenation is a concern. Fine. Depth of anesthesia, here depth of pressure, depth of C is a concern, where depth of anesthesia is a concern. Oxygenation is a concern, same way oxygen is a concern. So apart from these two concerns, other concern is gas volume deficiency, accumulation of toxic agent in the absorbent, and CO2 absorption. So we'll discuss first 3. CO2 absorption, most of you know how to tackle. ET CO2 monitoring already covered. So what is the, आप लोगों का saturation कितना होगा अभी? हाँ? 97, 98, 90 से नीचे वाला कौन है? No one. So, what is the amount of air? You are inhaling air. We are all inhaling air. Still, our saturation is 97, 98, 99, 100. True? Fine. Okay. What is the amount of air to be inhaled by us in a minute? Minute ventilation. And what is the percentage of oxygen in that air? So for a easy calculation, we'll keep 20%. Calculation easy हो जाएगा. Then, what is the volume of oxygen in the inhaled air? 20% of. That is 1.25.
20 के साथ 1 लीटर.
20 के साथ 1 liter. Fine. And what is your requirement? So this formula is a British formula through which you can calculate the metabolic need, our metabolic need, our oxygen consumption. That is 3.5 to 5 ml per kg. That's come to around 250 ml for a 50 kg. So we'll stick to that for easy calculation. So our need is 250 ml. And we have been supplied with. So God has given us 4 times more safety margin. Still under anesthesia, we are keeping 50%, 60%, 70%. Is it required? आप लोग एयर पे 98 कर लेते हो तो पेशेंट में इतनी जरूरत है नहीं है. So you are overdosing. So 30% is minimum required. Why 30%? Because under general anesthesia, there will be a shunting, there will be atelectasis. That needs to be compensated. That is the reason, थोड़ा बढ़ाते हैं तो 30% ले आते हैं. अगर if you are delivering 5 liter, 30% of 5 liter will be 1.5. That is more than enough. So do not increase your FiO2 beyond 40. That's not required. So minimum acceptable is 30%. Now, if your patient saturation is going down in spite of 30 to 40, think of other causes first. So, this is another important graph. This blue portion is nitrous. This is agent and this white is oxygen. This is showing uptake of agent in our body, and this is the duration of anesthesia. Confusion नहीं है ना पीछे? Yes or no? हाँ, ठीक है. So look at this. If you're starting the anesthesia for first 15 minutes, this is showing the nitrous uptake, this one is showing the agent uptake, and this is oxygen uptake. So initial first 15 minutes, nitrous uptake is 1400, 1600 up to 2 liter. And after 15 minutes, whatever the nitrous is going in, coming and exchange to the circle back. But oxygen throughout the anesthesia, the consumptions remain same, 250 ml per minute as per the metabolic need. Fine. So what is the importance of this graph? So initial 15 minute uptake of gases are on very high side, and that is the reason before starting the low flow, first 10 to 15 minutes you have to start with the high flow. Otherwise there will be a gas volume deficiency. Clear? Okay. So what is the difference between FD, FI, FA? बोलते रहते हैं मोटी में FD, FI, FA, mostly FI. All three are different terminology and it's having a different clinical impact. FD means what we deliver from the machine. FI means it's a concentration of mixture of FGF and rebreathing gas in the circle which patient is going to inspire. So FI, in a FD we can say concentration of gas at the machine outlet. Fi is a concentration of gas at circuit outlet, and both are totally different. It's not same. So you think that कि you are delivering 100% oxygen, setting the 100 flow under 10 liter of flow on the machine. No, it's FD. FD 100, but not FI. Okay. And ET, what we measure as an end tidal, that is alveolar concentration. So these three things are totally different. So when we are talking FD, means delivering the concentration from the machine. FI means what patient is going to inspire from the circle. And F end tidal, what we measure on the monitor. So during low flow, circuit contains two gases and rebreathing component is on higher side. Again repeating, during low flow. Okay. So depth of anesthesia and oxygenation is highly depend on the rebreathing gas. So now, this is schematic representation. This one is vaporizer, oxygen, nitrous, CO2 absorber, volume circuit, alveoli. This is bellows and reservoir. Now, suppose we have set the minute ventilation of 5 liter. Fine. And so we are first discussing about the concern of oxygen. What happens with the oxygen with low flow anesthesia? So when we are delivering 1 liter of flow, low flow means 1 liter, in which FdO2 is 50. And we have set the minute ventilation 5 liter. So this 500 ml is going to go into the circle, which is going to be mixed with the 4 liter of rebreathing gas. So that 500 ml is going to be diluted with the rebreathing gas. Fine. And this is the mixture which contains diluted oxygen is going to be inspired by a patient in the next breath. So inspired oxygen concentration is always lesser than the delivered oxygen concentration in low flow anesthesia. That we need to keep in mind. And that is the reason we have to have FiO2 monitor. So inspire oxygen concentration is always lesser than delivered in low flow anesthesia. Now what happens? Throughout the anesthesia time, whatever the oxygen is going into the patient is going to consume 250 ml per minute, and rest of the oxygen will come back into the circle. But whatever the nitrous after 10-15 minutes going into the patient is coming back to the circle. So over a period of time, gradually nitrous concentration is increasing and oxygen concentration is decreasing. And that is the reason with low flow anesthesia, FiO2 is gradually reducing over a period of time. That is another reason to use the FiO2 monitor. So this you should keep in mind. Fi is always lesser than Fd. And over a period of time, FiO2 is going to be reduced in low flow anesthesia. So monitor, many times we see that I am delivering 100% oxygen, patient is only having 50. Monitor is not wrong. You are wrong. Monitor is right. So now we'll discuss 3 case scenarios. How oxygenation is having clinical impact on the anesthesia. One case, we are inducing a 2 patient, conducting a low flow with the 2 patient. One is both are having 50 kg, same BMI, everything is same. All body parameters are same, no change. And one patient is been delivered with the 1 liter of flow. And second is delivered with the 500 ml, minimal flow. So now, so in both the patient, oxygen consumption is same. Fine. So now, and in both the patient, we are delivering 50% FdO2. So in 1 liter, we are delivering 500 ml in this case and 250 ml in this case. Now, patient is going to consume 250 ml Fine. So, from 500 ml, here patient is going to use the 250 ml. Now here delivering 250 ml and the whole 250 ml patient is going to use it. So fall of FiO2 is more significant in low flow and comparatively less. So that is you should have to keep in mind. As you go with the low with the flow, fall of FiO2 is more significant. Clear? So this showed in the graph. This one is with the 1 liter. This one is with the minimal flow, 0.5 liter. So fall of FiO2 is more significant with the minimal flow. So second scenario. One patient, 50 kg. Second patient, 100 kg. And we are delivering 50% FD with 1 liter of flow in both the patient. So flow is fixed, deliver oxygen is fixed, only change is this is 50 kg patient, this is 100 kg patient. So 50 kg, so from we are delivering 500 ml oxygen in both. Fine. So 50 kg patient, metabolic need is, upper limit is 5 ml per kg. So from 500 ml, this 50 kg patient is going to utilize 250 ml. And 100 kg, metabolic need is 100 into 500 ml. So it's going to 500 ml from the 500 ml. So fall of FiO2 is more significant in patient who is having a higher weight compared to lower weight. So this also you should keep in mind. When patient weight is higher, fall of FiO2 is more significant. Now third scenario. So that's shown in the graph. Third scenario. Again 2 patients. Same BMI. Body format is same. This patient again 1 liter. This patient again 1 liter. Both with the 1 liter. Now here we are using 50% FiO2. Here we are using 40% FiO2. Patient is going to use 250 ml, 50 kg hai to. So here 50% means from 500 ml he is going to use 250 ml. Here from 400 ml he is going to use 250 ml. So fall of FiO2 is more significant in this case compared to this case. So this is third scenario. As nitrous concentration in the inspired gas mixture increases, fall of FiO2 will become more significant. So three scenarios, three concerns. First, as you go down with the flow, as patient weight increases or increased weight, and third, as nitrous concentration increases, fall of FiO2. So if you are able to understand these three, you can play around with your low flow in a clinical practice. Now, what should be, whatever the component you are using, whatever the flow you are using, what should be the minimum oxygen flow during your low flow? That needs to be calculated with this Brody's formula. So, that is metabolic flow. For a simple sense, to be more safer side, keep a 5 ml per kg oxygen. Suppose it's a 50 kg patient, so it's a 250 ml. So, if you are using 400 ml total flow, in that 250 ml should be the oxygen. If you are using 1 liter, again minimum 250 ml should be the oxygen. So this is how you can customize your low flow anesthesia for more safety of the patient. Or 50 kg. Suppose you are having 100 kg patient, then the metabolic need is 500. So your oxygen flow should not be less than 500 ml. That's simple thing. Suppose you are using metabolic flow, 600 ml or 500 ml, there should be 100% oxygen. You can't add air or nitrous. So this is how you can titrate your low flow percentage of oxygen. So that is the reason, as you go down with the flow, you have to increase the FiO2 concentration. And you are delivering the metabolic flow, that is always 100% oxygen. And when you are using the metabolic flow, always use it with the keeping the alveoli open by use of PEEP, because it prevents the absorption atelectasis. So during low flow, your FGF, oxygen should be always equal to or more than metabolic flow and lesser than the conventional flow. You can safely use for 50 to 70 kg patient 1 liter with the 50% oxygen without FiO2 monitor for at least 2 hours. For 2 hours, your FiO2 will not go down less than 30. And if you are using 0.5 liter of flow with 50% FiO2, then you should have FiO2 monitor. 50% deliver O2, then you should have FiO2 monitor. So this is very interesting publication. According to this publication, 0.6 liter of flow with 50% FiO2 you can safely use for 2 hours for patient weighing less than 70 kg. So condition 1, weight is less than 70 and limit up to 2 hours. Why? Look at this. So this is the graph showing the 30% FiO2. Fine. No, now look at this. At 2 hours, it reaches the 35. It's going down. So that's the reason for 2 hours of surgery with 50% FiO2, 0.6 liter of flow, you can safely use for 2 hours without monitor. Ideally, you should have monitor. So this is, in Gujarat we call it as a Gola method. Simple method, कुछ भी नहीं है तो कैसे करना है, वो graph है. So if you are starting with this graph, this table is for 50 to 80 kg. I am going to share it with you. 50 to 80 kg patient. To start, those who are using 1 liter of flow, initially high flow, then at the 15 minute, reduce to 0.5, 50% FiO2. You can continue throughout the surgery for 3 hours. Don't have to change. Will be fine for oxygenation. But if you are using 60% nitrous, 40% oxygen, then at the end of 45 minutes, you have to change the concentration to 50-50. Then throughout safe. If you are using 0.5 liter of flow with the 50% FiO2, 0.25, then at the end of 30 minutes, you have to change to the 60% oxygen and 40% nitrous. And at the end of 90 minutes, you have to change to 70% oxygen and 30% nitrous. Then you can continue further. So third method, what was the first one? Time constant. Second, 2 component of gases. Third, FiO2 is always lesser than delivered. And FiO2 is going to be reduced over a period of time. And as patient weight increases, as you go down with the flow, or as your nitrous concentration increases, fall of FiO2 is more significant. Clear? So, second concern is the depth of anesthesia with the low flow. Means achieving proper concentration in the alveoli and maintaining that concentration throughout the anesthesia. That is concern. So, how to do it? Fine. What is the dose of thiopenton as IV anesthetic agent? 5 milligram. 5 to 7. 5 to 7 milligram. So, or what is the dose of propofol as an IV anesthetic agent? 2.5 to 2.5 milligram per kg. So, if we are delivering this dose, we are sure we are having surety that for 5 to 7 minutes, patient will be having optimal depth of anesthesia. Yes? So, you know all the doses for clinical application of your anesthesia during induction. No. Now, what is the dose of inhalation agent to achieve adequate depth of anesthesia? What is the concentration of inhalation agent where your patient will be having optimal depth of anesthesia? MAC value. You are saying MAC value. How are we delivering our anesthesia if you are not knowing the dose? कैसे करते हैं? चलता है, हो जाता है. Or else we are always overdosing. That is also possible, and that can lead to POCD long-term memory loss, short-term memory loss in the patients. So we are making the harm to the patient by overdosing our patient. So that's confusion. We don't know what to be delivered in low flow anesthesia. Any anesthesia, any inhalation agent anesthesia. Where to achieve, whether it's to be achieved in the alveoli or brain, or how to achieve, when to achieve, and why this. So I'll make it clear, depth of anesthesia with the low flow, and we'll define the proper concentration of inhalation agent to prevent awareness. Then and then we'll be able to deliver proper low flow anesthesia. Suppose this is a graph. This line is showing the proper depth of anesthesia line. So at this line, all the patient will not be having awareness. Now initially most of us are using the propofol as a IV induction agent, and if we deliver a proper dose of propofol, so propofol concentration gradually rises. At this point, patient will not be having awareness. Then gradually start reducing. At this point, patient will be having awareness. So it will give 5 to 7 minutes of proper depth of anesthesia. Fine. So when we are mixing inhalation agent in our anesthesia practice, at this point, inhalation agent should take care of depth of anesthesia. होता है? True. That's the basic anesthesia concept. Now, because of hypotension during induction, many times, we are not starting the inhalation agent. ये लाइन शिफ्ट हो जाती है. So this is the area where there are maximum chances of awareness. And most of us, even I was doing same thing. Hypotension हुआ है, अभी inhalation agent start नहीं करना है. Now think that if you apply this time constant theory, it will take almost 6 time constant to achieve the proper concentration in the alveoli. So whatever you are delivering, you are not directly going to the patient. And to have a hemodynamic instability with the inhalation agent, it requires 1.5 to 1.8 Mach value. Then and then there will be hemodynamic stability. Otherwise not. So correct the hypovolemia, but start the inhalation agent. Because it will take another 5 to 7 minutes to achieve proper concentration which prevent awareness into the alveoli. Otherwise, there are likely chances your patient will be having awareness in this phase. Where to achieve? So brain or alveoli? Ideally it should be in the brain. But we are not able to measure the concentration in the brain. That's the reason we are relying upon the alveoli, because we can easily measure the end tidal concentration. What should be the concentration? One answer I get, that is Mach value. Should we get Mach value or higher than that or lesser than that? We are not clear. Okay. So to define that value, we have to understand what anesthesia is. So this Goodall, most of us are knowing, Goodall's, who has measured the depth of anesthesia in a subjective way, in 4 stages: delirium, analgesia, surgical plane of anesthesia, and medullary suppression. Fine. And we were measuring the depth of anesthesia by this parameter: change in the pupil size, respiratory pattern, hemodynamic instability. Fine. So these are subjective criteria. So if you are using, आप CO और DAS में देखते हैं pupil कितना है, depth कितना है. So we need to have a unit for depth of anesthesia. And if you are having a unit, then and then we can compare the potency of inhalation agent with each other. Otherwise we can't. Why this subjective criteria we can't? So to define the unit of depth of anesthesia, what we consider Mach, Agar has come out with this concept. And according to this concept, what is MEC? Minimal alveolar concentration required to prevent purposeful movement in 50% of the patient when exposed to noxious stimuli. Clear? So MEC, so we consider MEC as a depth of anesthesia unit, but it's not. Why? We'll discuss in the next slides. So we consider this as a unit. What does it mean, MEC? ISO MEC is 1%, CO MEC is 2%, and DES MEC is a 6%. What does it give the information? What is actually is 1%, 2% or 6%? What we set on the dial? No, it's not dial. It's end-tidal. So it means that if we achieve 1% end-tidal with CO, 2% end-tidal with 1% end-tidal with ISO, 2% end-tidal with CO, and 6% end-tidal with desfluran, it means that 50% of my patient will not move to surgical stimuli. Clear? So it's not about preventing awareness. So when we are talking a MEC, when we are discussing the MEC, when we are writing the MEC in the exam, it always represents immobility. So it's a unit of immobility, not depth of anesthesia. And as such, we are achieving the immobility with the relaxant. So this is not required then. Still we are think that MEC should be there. So we should not accept MEC as our depth of anesthesia unit. Then what should be the actual unit? Again, we have to understand anesthesia. What is anesthesia? Definition? PGs. Third year, second year. Future anesthesiologist हो आप लोग. It's a reversible loss of consciousness in which persons neither perceive nor recollect the noxious stimuli. So it's about the perceivance and recollection of the noxious stimuli. That is anesthesia is. And Press Robert has come out with the concept. There are two components of anesthesia. One, actual component. Actual component means suppression of conscious perception of noxious stimuli. That is actual component. That has to be there in all anesthesia. Patient should not have awareness. That is our primary goal and mandatory goal. And the desirable, which is there or not, is fine. That is analgesia, hemodynamic stability, and muscle relaxation. These are the desirable components. And Agar has come out with the conclusion that all inhalation agents possess two reversible conditions or provide two reversible conditions. One, amnesia. Second, immobility. Now, what is the dose of thiopentone as IV anesthetic agent? 5 to 7. And what is the dose of thiopentone as an anticonvulsant? 2 to 3. 2 to 2.5 or 2 to 3 milligram. So, dose is different to get different effect. Same way, the concentration required to achieve amnesia is totally different from the concentration required to achieve immobility. And when we try to achieve immobility, we are always overdosing our patient. Always. So, we need to achieve amnesia. Fine. So, what is amnesia? Means no memory. So, why we are special? This slide shows that. Why we all are special and different from all other speciality. No memory recall. कभी ऐसा हुआ है कि आपका पेशेंट बाहर आया और अपना नाम भूल गया? नहीं हुआ. That is the reason we are special. So there are two type of memory. Explicit memory, that is called conscious memory, and implicit memory, that is unconscious, total unconsciousness. When patients met with an accident and having a head injury, that is implicit memory. Many times not able to recollect what he is. And in explicit memory, there are again two type of memory. Episodic memory, that is memory of the event, memory of the procedure, memory of that patient in the OR, memory of the surgery. And semantic memory is a memory of the its own existence in the world. Means my name, my relation with my wife, my relation with my brother, my relation with you, that is this memory. ये तो भूलता नहीं है कोई. My wife is there, otherwise I will call you. Call that. If I get this memory, I lost this memory, I'm not able to recollect, I am her, she is my wife. That happens, but it's not happening. So we are focusing very pinpointly only on episodic memory. And only an anesthesiologist can do it, none of other specialists can do it. And that's the reason we are special. So unit should be make amnesia. And amnesia is the anesthetic concentration required to suppress recollection of noxious stimuli in 50% of the patient. But it's not possible to measure amnesia. कैसे पता चलेगा ये amnesic है कि नहीं और कौन से डोज पे है कि नहीं? It's not possible to measure. So we have to rely upon another unit, that is called make awake. So make awake is an anesthetic concentration required to suppress a voluntary response to verbal command in 50% of the patient. कैसे make awake define किया गया? They have anesthetized all the patient. Then they have gradually reduced the concentration of inhalation agent. And they were giving the verbal command to the patient. And when patient started responding, that is plotted on the graph. And when 50% patient has responded to that verbal command, that is labeled as make awake. And make awake is always higher than make amnesic value. And that is the reason we should rely upon make awake. So, make awake should be the concentration, that should be the unit for depth of anesthesia. So, make awake can be easily calculated by 35 to 40% of the make. 35 to 40% of the actual make value of the inhalation agent. To considering that, isoflurane make value is 1. 35 to 40 is 0.34 or 0.35 is a make awake. Sevoflurane 0.7 to 0.75. We can consider 0.75. 2% is make. Desflurane 2 to 2.6%. So now, should we consider this as our depth of anesthesia unit? Acceptable or not? No, it's not. Because, look at this. It's only for the 50% of the patient. What about the rest 50%? So, Agar has again come out with the formula. If you achieve the twice of make awake concentration, none of your patient will be having awareness. None. And that is the concentration we should target for. And that is for sevoflurane 0.75 make awake, twice of that is 1.5. So if we achieve 1.5% end-tidal concentration with the sevoflurane, none of your patient will be having awareness. So that is the concentration for sevo. For iso, 1 is a make, 0.35 is a make awake, twice of make awake is 0.7. So those who are using isoflurane, target concentration should be 0.7% end-tidal. And dash fluorine is almost 4%. So again repeating, your target minimum concentration to prevent awareness for sevoflurane anesthesia is 1.5% end-tidal, for isoflurane 0.7% end-tidal, and for dash fluorine 4% end-tidal. If you are able to achieve this, none of patients will be having awareness. That is for sure. So now you know the concentration and dose of inhalation agent. So all of your inhalation anesthesia, your target concentration is again 0.7 ISO, 1.5 CO and 4 DES. Now confusion again. Someone is going to ask me a question at the end of the session. If I am adding opioid in my clinical practice, does it change this concentration? Decrease this requirement of achieving awareness, preventing awareness? Or I am using nitrous also in my clinical practice. It decreases. So if you look at the MAC, see, we know nitrous decreases the MAC. Opioid decreases the MAC. So what's the definition of MAC? What MAC represents? Immobility. So adding nitrous or adding opioid decreases the requirement of inhalation agent to achieve immobility, not preventing awareness. So opioid or nitrous do not have impact on MAC awake value. So whether you use opioid in your clinical practice or use nitrous in your clinical practice, your target concentration will remain same, 1.5 end-tidal CO with CO, 0.7 with ISO and 4 with DES. Whatever the addition you use in your clinical practice. So this concentration is to prevent awareness. So then why to use opioid? Why to use nitrous? Many people are using nitrous. We are not using nitrous. How it is making difference in a clinical practice? So there are number of sibling of MAC we know. One is MAC line. Fine. Then MAC awake, which is lesser than the MAC line. 2 MAC awake is between the MAC and 2 MAC awake. MAC and MAC awake. MAC, there is another sibling MAC analgesia. MAC bar, which prevents the automatic reflex. Fine. So that MAC analgesia and MAC bar is at the level of MAC or above the level of MAC. Fine. So if you add opioid, it decreases this MAC bar and MAC analgesia. So now giving you a clinical example, suppose you are conducting a case, your end-tidal is 1.5 with the CO and sudden there is a change in the pulse rate. An increase in the blood pressure. It does not mean that patient is having awareness. You have maintained the optimal depth of anesthesia, but you have not controlled the MAC bar and MAC analgesia. That is desirable component. Analgesia, autonomic reflex control, and relaxation, these three are desirable component. So to take the desirable component in your control, you have to add analgesic, opioid or pharmacological method. That's called balanced anesthesia technique. So we'll come to that balanced anesthesia technique. Only factor which impact the MAC awake, that is age. So this is again interesting graph. This is showing 100% of the patient. This is showing variation of MAC, 0.5, 0.2, 1 MAC, 2 MAC, 3 MAC, like this. Now, this graph represents awareness. This graph represents immobility. This analgesia. And this one, hemodynamic stability, autonomic reflex control. So, if you achieve this concentration, none of the patient will be having awareness. This concentration? Yes or no? Fine. So that is, So now again, so this concentration is a MAC awake, 50% is aware. This is 50% immobile. 50% is having analgesia and 50% is having hemodynamic stability. So this concentration, if you achieve this concentration, none of your patient will be having awareness. That is 2 MAC awake concentration. That is 1.5 CO, 4 DAS and 0.7 ISO. Now, by achieving this concentration, you are not controlling immobility, analgesia and autonomic reflex control. So that can be done by pharmacological method, or opioid, or relaxant, or regional. So when you are achieving the end-tidal optimal level 1.5 is CO, along with these three things, controlling this desired factor, that is actually called balance anesthesia technique. So first, second, third, yaad hai na? For proper depth of anesthesia, optimal depth of anesthesia, CO 1.5% end-tidal, ISO 0.7% end-tidal, and DAS 4% end-tidal. You know this schematic representation. Patient attached with the machine. Initially we had discussed this with the oxygen. Now look at this. Now you are delivering 50% deliver oxygen, FDO2 50 with 0.6 liter of flow. And you have set the minute ventilation 5 liter. So this 0.6 liter and the dial concentration you have kept the 3. So FD agent is for CO is a 3%. So this 3% 0.6 liter of flow is going into the circle, which is going to be diluted with 4.4 liter of rebreathing gas. And this is the mixture. Now suppose you have set, you have achieved the end-tidal 1.5. So this 4.4 liter contains the 1.5% CO. So this concentration is a mixture of 1.5% rebreathing gas and 3% fresh gas. And this is the mixture which is, so it's the concentration of this mixture will be between the 1.5 and 3. True? So this is the mixture which is going to be inspired in a next breath. And which is having inspired concentration is always lesser than that. So inspired agent concentration is always lesser than delivered in low flow anesthesia, like oxygen. Now, suppose it's coming to the 2%, between 1.5 to 3. Now from patient, certain agent is going to be taken up. So expire is lesser than 2%. We consider as a 1.5, that we consider as end-tidal. So alveolar or end-tidal concentration is always lesser than inspired. Inspired is always lesser than delivered in low flow anesthesia. So if you are monitoring the low flow anesthesia with the agent monitor, and if you get this FD is higher than FI, FI is higher than FA, you are delivering proper low flow anesthesia. Clear this part? During low flow, you are having steady state of anesthesia because of low time constant, high time constant, because of high time constant, you are not able to change the depth, proper concentration, alveolar concentration speedily. Second, depth of anesthesia is highly depend on the rebreathing gas. That's the reason. Rebreathing component is on very high side on low flow anesthesia. That's the another reason you can't change the depth of anesthesia. So these are the two reasons you have steady state of anesthesia with the low flow. And this very important point. What happens? Suppose bellow is getting down during surgery. What we do? flush. करते हैं ना? So if you flush, your job is gone. See what happens. Your depth of anesthesia, I mean alveolar concentration which you have built up, that is highly depend on the concentration in the circle. And if you have flush out, gone. So never flush during low flow anesthesia. So if you want to increase the height of bellow, for a while increase the flow which can take the agent with it and then decrease the flow. Achieve the height, then decrease the flow. For easy remembrance, one sentence. Never use flush except toilet. अभी याद रह जाएगा आपको. हर रोज याद आएगा अभी. How low we can flow. This graph we have seen. This is the demand. This blue line is the demand. That is requirement, patient uptake. So if you are supplying the volume as for the uptake, then it's the optimal level of low flow, best effective low flow anesthesia. So that is called volume of delivery and volume of uptake. VD upon VU, if it is remaining near 1, that is best way. It's not possible to achieve 1, but you can reach near to the 1. And many anesthesia workstation shows this VD upon VU value. There are different ways they can explain on the graph. So how to, in a clinical practice, how to go ahead with the low flow? Initially with high flow. With the high flow 10 to 15 minutes, you will be able to achieve the proper concentration in the alveoli. So it's like a driving a car. Speed पकड़ने की है तो accelerator दबाओ. Once you achieve speed, just tap करके रखो. Then you start with the low flow. Depth of anesthesia will be maintained. Now question is, what should be the high flow? It should be 100, first 10 to 15 minutes, 100 ml per kg or circuit volume, whichever is higher. Fine. So suppose again we case the two different case scenarios. Now you have been given chance to deliver anesthesia for 80 kg patient. With the circuit volume of the machine is 6 liter. What should be your flow? And now you are inducing a pediatric patient of 20 kg on the same machine. What should be your flow? 6 liter circuit volume. What circuit volume is 5? 5. So 100 ml per kg or circuit volume, whichever is higher. So as we discussed, so end tidal is 1.5. That is our target. And during anesthesia, if you are keeping dial 1%, how will you be able to achieve 1.5%? होगा ही नहीं. Possible ही नहीं है. And if you are flowing low, even if you are keeping 1.5%, make no sense. So that is called depth, over pressure delivery. As you go down with the flow, you have to deliver more pressure. So that's the reason with CO, you require CO ISO, you need to require higher than the MAC value. But you are going to achieve 0.7 with the ISO, 1.5 with the end tidal, 1.5 with the CO and 4% with this. So if you want to achieve 1.5 and if you are keeping 1.5, you never get 1.5. Because FD, FI, FA, that you have to calculate. So in a simple sense, suppose your maintenance flow, initially you have achieved proper depth with the high flow. Now 2 liter, 1 liter and 0.5 liter. Suppose someone is using 2 liters, someone is using 1 liter, someone is using 0.5 liter. So your dial concentration should range from 2 to 3, never 1.5. If you are using 2, 2 will be fine. If you are using 0.5, 3% will be fine. So from 2 to 0.5, you can change the dial from between 2 to 3, but never less than 2. If you are using more than 2 liter of flow, then you can keep 2% or little bit lesser than that. So for easy calculation, your target is 1 point for a CO. You consider ISO and dash as per these graphs, as per table. Suppose target is 1.5. Now, if you are reducing the flow to 0.5 for 50 to 70 kg patient, to start with, this is for a safer, we have considered 8 liter flow. Up to 70 hai, up to 80 tak we can pull on. So start with 8 liter of flow, 3% dial. Within 10 minutes, you will be able to achieve more than 1.5. Then reduce the flow to 0.5 and keep the dial setting 3.5. Continue with it for the 60 minutes. After 60 minutes, change the dial to 3 and you can continue same thing throughout the surgery. You don't have to change the dial. But when you are using 1 liter of flow with 8.3, keep the dial 2.5, 1 liter of flow at the end of 10 minutes. Throughout the surgery, you don't need to change the dial. And for 2 liter, don't use 2 liter. That is for ISO. So, fourth message was concentration of agent to achieve adequate depth of anesthesia. CO 1.5, ISO 0.7-4. Fine. Third, about oxygenation. Second, about component of gas. First, about time constant. So, FD is always higher than FI, FI is always higher than FA in low flow anesthesia. Initial high flow either 100 ml per kg or more than the circuit volume, whichever is higher. And ये तो बोलने वाला नहीं है अभी कोई. So look at the wastage we are making. This is the requirement, that yellow line. Fine. Uptake and deliver same. But if you are using 0.5, so between this 0.5 and a yellow line, red line here, these are the wastage. Even with the 0.5 liter. 1 liter, look at the wastage. 5 times more than the requirement. And 1.5, almost 10 times more than the requirement. You are wasting. And 2 liter, रखा ही नहीं है ग्राफ में. So last part of the session, gas volume deficiency. What is gas volume deficiency? What is the amount of air to be inhaled by us in a minute? So if you have been supplied with lesser, there will be a deficiency. That is called gas volume deficiency. So if circle is having the volume lesser than the requirement, that is gas volume deficiency. So when it happens? When this gas volume deficiency happens? First, excessive leak is there. Then gas volume deficiency can happen. Or uptake is more. Then gas volume deficiency can happen. When uptake is more, initial 15-minute uptake is more. Fine. Certain cases like patient with fever, higher metabolic rate, where uptake is more. Now, suppose someone is reducing the flow at end of 5 minutes of start. So nitrous uptake is more and you have reduced the nitric uptake is almost 2 liter and you have reduced the flow to 0.5 liter. This creates gas volume deficiency. Fine. And that is another reason you should have to continue for 10 to 15 minutes with the high flow. So there are two reasons. Uptake is more and leak is there. That creates the gas volume deficiency. So these both things needs to be compensated during your anesthesia. And that is where the role of self-check is coming. Anesthesia workstation is coming. Because suppose how low you can flow. Your lowest flow should be uptake plus leak. दो सपोज 300 ml कोई पेशेंट ले रहा है और 200 ml लीक है तो लोएस्ट फ्लो शुड बी 500 ml. So this is how you can decide your lowest flow. And as you go down with the low flow, percentage of oxygen increases. That you should keep in mind. Fine. So now I am giving, so you have to match your flow depend on the patient uptake and leak. So that's the reason always you have to do a self-testing of the machine, because by self-testing it will give you the exact amount of leak. So that is the next session by Dr. Amit. Suppose your machine leak is having 200 ml and you are conducting the case of 100 kg patient. What should be your lowest flow? So metabolic need is 5 ml per kg, 100% oxygen, 500 ml plus 200 ml leak, 700 ml. So that is how you should titrate your low flow anesthesia. Suppose you are using supraglottic airway devices. When you have supraglottic airway devices, you have to think of that each supraglottic airway device is having a ceiling pressure. If your airway pressure goes beyond that ceiling pressure, it starts leaking. Then you have to compensate that leak during your anesthesia. Or else you can keep the pressure control lesser than the airway ceiling pressure. So there will not be any leak. Pressure control ventilation पे रख दिया. Airway, suppose airway ceiling pressure कोई supraglottic का 25 है. Fine. So beyond, if your airway pressure goes beyond 25, start leaking, you have to compensate that leak by the flow. Now, if you are change that mode to pressure control and keep the pressure control upper limit less than 25, then there will not be any leak. This is how you can titrate the low flow with the supraglottic airway devices. So, important thing is to diagnose that there is a gas volume deficiency. How to diagnose? Those who are using bellows, if your bellows is going down gradually, that is suggestive of gas volume deficiency. Or those who are using the piston based machine, if bag is collapsing, that is suggestive of gas volume deficiency. Or your plate 2 pressure is going down with the piston based machine, that is suggestive of gas volume deficiency. So whenever there is a gas volume deficiency, you have to compensate that deficiency by increasing the flow. So last message. 5 तो याद होगा ही अभी. Gas volume deficiency diagnosed by the fall in bellows height or fall in the plate 2 pressure and collapsing bag in a piston based machine. Keep the FGF equal or more than summation of leak plus uptake. And when you are using, as you are going down with the flow, you have to increase the concentration of oxygen. And as you are reaching the metabolic flow, it should be 100% oxygen. And nitrous free anesthesia is preferable to prevent the gas volume deficiency. अगर nitrous ही नहीं है तो gas volume deficiency इतनी होगी नहीं. First, second, ये 6 आ गया तो लो फ्लो हो गया. 3, 4th, 5th,